Hello, dear colleagues. I'm Alfonso Caiazzo, an oral surgeon from Salerno, Italy. And in my professional life, I've always been passionate about finding the best way to reach and to achieve long-term stability in my implant cases in my daily private practice. During this presentation, I will try to share my knowledge, my approach, and my philosophy, of course, with the support of the most recent literature. In the presentation today, and as you can see, the title is the use of Straumann screw retain abutments to enhance the clinical results in immediate implant treatments. You already see that there is an introduction. There is the introduction of a new element, of an extra element, the screw retain abutment, which I use in most of the cases I do now. And some of you might think that this could be cost effective and be an adjunctive cost on your practice. But this is true in the short term, because you have to buy an extra element. But I will demonstrate at the end of the presentation that this is not true, because in the long term, you will save money and visits to the patients. So I was talking about stability at the beginning, and the way I want to reach the stability and my passion about reaching the stability, because, I want to be playing safe on my patient and have the best long-term results possible. So what you look at that when you're talking about stability, of course, is hard and soft tissues. Unfortunately, during this webinar, I won't have the time to go over the necessity of the quantity of bone you need, the soft tissues you need, the quantity of soft tissue we need. I'm assuming that all of us are familiar with those numbers and with those quantity. But let's look at the bone loss and the bone around the implants when you're placing implants. What happens? Albertson in 2017 states that you might see some early bone loss around the implants, and some of the bone loss is considered kind of physiological. It's a kind of remodeling more than loosening bone. But if you're losing more of a small remodeling, and you start having an aseptic loosening, what you see after 1 year. So if you lose a little amount of bone up to 1 year, this is considered physiological. But if you see more than loosening of bone more than 1 year along your follow-up, that should tell you something, because this is a predictor for a peri-implant pathology. So if you see more loosening along the years, you're going towards a peri-implantitis. And this is a very nice article, and I really suggest to all of you to read it. Looking at even more literature, a 10-year prospective cohort study published more recent, 2021, is saying that the early bone loss is a predictor for long-term peri-implant pathology. This is true, but it's not the only factor, of course. I mean, there are other factors that might influence the long-term peri-implant pathology, like, for example, periodontal status, periodontal pathology, smoking habit, general health of the patient. But early bone loss is one thing you want to look at that when you're looking at long-term stability. Now, when we're using implants, we have two components, the surgical component and the prosthetical component. Let's look at the prosthetic component above the bone as the abutment and the crown. Now I'm placing an abutment. I used to place the abutment at the collar of the implant, at the head of the implant, without any distance between the abutment and the implant. But from my clinical cases, I noticed that the height of the abutment might influence the stability of the bone. So I went back and I looked at the literature, because I always do this. Whenever I have a question or I have a doubt, I go into the literature. And what I've seen is that the abutment height really might influence the amount of bone you lose in the long term. This article from 2014 states that marginal bone loss rates at 6 and 18 months were mainly affected by the abutment height. So one thing I know now is the height of my abutment might be very important for the stability of the crestal bone. And we see more in the literature, whenever you use a short abutments, you see more bone loss. It's out there. Even if you're using a single implant or two implants next to each other, you should use always a longer implant. And even when you compare the two things, this article by Pico published in 2019. It is very nice because he compares two different technique or two different abutments. He uses long and short. And they notice that in short abutments, you will lose more bone. So the idea is to try to use always a longer abutment in order to have a more stable crystal bone, because you don't want a connection to be right at the head of the implant. But let's see some clinical cases so I can be more clear and it's easier for you to understand. I was one of the first users of the BLX system. I'm sure you all familiar with the BLX system, which is the taper implant by Straumann. And I was called to Basel in 2017 for the presentation of the implant. I think it was the spring in 2017. And then by the end of the year, I started using it. I started using the system, so 2017, 2018. And of course, whenever I use a new tool, I don't want to jump on very difficult cases. I don't want to start with the most demanding cases, the static, immediate loading. So I was using it in a healed bone, pretty straightforward, single implant and a healthy patient, nothing special. But placing the implant, placing the healing abutment, when there are no many issues, I always go one stage. I don't choose the two-stage approach. And then this is the final case. After a couple of months, this is an SLA active. So after 4 to 6 weeks, I take the impression and finalize the case. But see at the abutment is not sitting, the variobase is not sitting on the head of the implant. Have a distance between the profile of the crown and the head of the implant. And I follow this case along the line, and 6 months were stable in soft and hard tissues. 1 year were still stable, perfect, happy. 2 years stable. I haven't lost any bone. So I don't see any early bone loss here. So there is no predictor for peri-implant pathology after 2 years. And after 45 months, we're still stable, exactly the same. Actually, I should say that there is a little bit of growth of bone around the head of the implant if you can get close. It depends on the device you're looking at the presentation on, but there is a little growth above the head of the implant. But so, and this is because I think I'm using a variobase away from the head of the implant. But now, if you use a high abutment, sometimes you might not have the space to place a high abutment. So what's the consequence of doing this? Is placing the implant deeper. Or if we look at the other way around, if surgically you place the implant deeper, you need a longer abutment. But is this influencing your crestal bone in the long and in the mid and in the long term? Again, we go back to the literature. We look at the articles we have, the studies. We have 1 year randomized clinical study that is saying that if you place a deeper implant and a long abutment, you have minimal interproximal bone loss, especially into implants that are close together. In this case, the study was done with 3 millimeter and 1 millimeter abutment. So they were comparing the 1 millimeter and the 3 millimeter abutment, and they saw that basically that with 3 millimeter abutment, there was minimal interproximal bone loss. if we're placing an implant subcrestal. You know, I was going always crestal. Then from some years back, I'm going subcrestal because of the literature and because these new approaches, this new philosophy. So you can place the subcrestal implant with the long healing abutment and you maintain the bone. So do we have a support to place an implant subcrestal? Is there anything out there saying that placing an implant deeper will help us? Yes, there is plenty of literature out there. Linkevicius, 2020. You know, Linkevicius says always the zero bone loss theory and philosophy and technique. This is influenced by the soft tissue, hard tissue, and by implant positioning and implant time position. But basically, he says in a 2-year clinical randomized clinical trial that if you place the implant subcrestal, you might reduce significantly the crestal bone loss. So you have another thing to think about when you're placing an implant: crestal, subcrestal. How deep should I go? I always like when I give this presentation, talk about and describe this article, because first of all, this is a friend of mine, Claudio Sacchi, and then he's Italian, and then the last but not the least is very recent article was published in April 2023, so a few months ago. And they were placing the implants 1 or 2 millimeters subcrestal. And they've seen that 2 millimeters subcrestal placed implant will show less thread exposure, or there is no thread exposure. So this could be a prevention against this subsequent peri-implant pathology. So now we've seen that subcrestal and longer abutment will help to maintain the bone, according to the literature and the systematic review. The critique that always arises when I talk about this topic is that if you have a soft tissue, very high soft tissue from the implant to the crown, is there a risk of developing an inflammation and then an infection and a mucositis and then a periimplantitis? And this critical review published in Coir in 2021 states there is at the present no solid evidence to state so to saying that increasing the vertical height of the peri-implant soft tissues alone would increase the risk of periimplantitis. So I feel pretty safe in doing what I'm doing because I have literature out there supporting what I'm doing. Now, we've done BLX cases on healed bone. I was moving forward and doing more demanding cases. One of the cases that you're seeing here is after a GBR technique. I regenerated some bone in the posterior maxilla, as you can see from the granules from the X-ray, and I used a BLX implant. Placing the implant subcrestal. Now I'm going subcrestal, healing abutment, straightforward, always the same. I'm always consistent. I always do the same technique to be consistent, and I want to be consistent to be successful, actually. And this is the final case. See, the implant is subcrestal. There is a variobase away from the head of the implant. Follow-up at 6 months. This man is an 82-year-old man, and he could care less about the aesthetic on the second premolar. I can't force him to replace the crown. He's happy with what he has, so I'm not pushing him to replace that the crown. 6 months stable. You still see some granules around the implant from the regenerative procedure. 1 year, you see less and less granules, but the 3-year follow-up, the case is perfect. Bone grown around the head of the implant, surrounding the implant all around. You have no bone loss at all. You don't have any remodeling at all. So this is stable, and this will be stable for long time. And again, we don't have a connection between the crown per se with the head of the implant. even more demanding cases, because the BLX is perfect for post-extractive immediate loading. We'll see this in a little bit. Immediate delay, that this is the approach I have all the time. Now when I'm familiar with the implant system, I'm happy with the implant, with the performances of the implant. I always go immediate delay. If I cannot go immediate. Immediate delay means 6 to 8 weeks after extraction. This patient was referred by a dentist. He forgot to take out a root tip, but it's okay. It doesn't really affect the final placement. So I open the flap, I place the implant. Since I don't have enough bone around the implant mesially, I rather go, in this case, submerged. So I do a two-stage approach. I place some xenograft, as you can see from this slide, at the crest of the gap. I don't go deep into the gap because I want some bone growing around the implant without any grafting material around. And this is quite clear in this X-ray of the final restoration. You see the grafting material just at the crestal bone, not deep into the socket, into the previous socket. But this is a stable case, and you see the maturation of the granules and the growing of the bone around the head of the implant. 1 year follow-up, the soft tissues are stable, the bone is growing around the head of the implant. 3 years now, the implant is completely submerged. There are no granules anymore. It's all bone, and the implant is stable, and soft tissues are stable. So I'm really happy with these results. But one thing that worries me is when I don't do prosto. I'm an oral surgeon. I don't do any prosto in my office. I have a prosthodontist in the office. We're a multi-practice clinic. So, but I always think, that he uses screwdrivers. He takes out the healing abutment, and then he takes out the temporary. Then he put the scam body, or he takes the impression and connect and disconnected the elements many times, and this is really worrisome to me. So it's very popular to say, oh, I do the one abutment one time, one abutment one time, one abutment one time. Can you really go one abutment one time when you do in these cases? You can't, because you should place a final abutment. How can you place a final abutment without an impression or things like that? And is this helpful to your bone level, for your bone level? And a systematic review of human studies published in 2019 says that minimizing the number of abutment, dis and reconnections would be beneficial to ensure minimal disruption to the peri-implant tissue, and again, to the marginal bone level. So one thing I'm still missing in what I've said to be stable with the marginal bone level is the one abutment one time, because the way I've shown you so far, I can go one abutment one time. But the easiest way to go one abutment one time is to place a final abutment that will keep the distance from the head of the implant, from the final crown. We do this many times when we do full arches. Now, this is a very demanding case, and there is no vertical dimension, so we had to work on the vertical dimension, go through full dentures, removable, to increase the vertical dimension. So I'm not talking about this case. I'm just showing that in many cases we use a one abutment one time. We use the SRA. Now we can use the SRA when we place the implants, or we can use the SRA at the end. But if we place the SRA at the beginning, when we do surgery, that's the one abutment one time. And we will never move that SRA again. And our prosthodontist, or you, if you're the prosthodontist, will work on the head of the SRA without going again into the tissues and connecting and reconnecting and disconnecting the screws and the elements all the time. So you put the SRA and you leave it there, and you never move it. That's my approach now, even for single cases. And Of course, I want to show you some cases the way I do it now, and the way I put all the things together: the depth of the implant, the height of the abutment, and the one abutment, one time technique. This is Elvira. Elvira is a colleague. She's a physician. She's in her 60s. She went for hip replacement. During surgery, actually, during anesthesia, unfortunately, the anesthesiologist broke during the intubation, broke her central incisor, right central incisor. She came to me, she said, Alfonso, I'm desperate, this tooth moves, I see pus coming from the gums, I need something, do something for me, please, and do it fast, because I don't want to go around without the tooth in the front. Of course, when you're looking at frontal teeth, you want to evaluate the difficulty of the case and see if you're capable of handling a case that difficult. And you want to look at the straightforward, advanced, complex classification in implant dentistry. This is published in the ITI Treatment Guide, volume 10. And if you never read it, go ahead and read it, because this is very, very important to know. So once I've looked at this chart, I decide which way to go. But the first thing I want to do is evaluate in the soft tissue clinically, radiographically, and the hard tissues radiographically. So I don't think it's an overtreatment to take a CBCT when you're looking at a case like this, because you need to study the socket. You want to make sure there is a buccal plate, all the walls are intact, and then doing these cases guided, you definitely need a CBCT. Now, in partially edentulous cases, can you use a full immediate loading and immediate placement and immediate loading technique? Now, if we were in a meeting, you were sitting in front of me right now, I will ask who will go for immediate placement, and I'm sure some of you will go for immediate placement. If I ask who would go for immediate delayed waiting for 6 weeks, I'm sure that people out there will say, yes, I go for immediate delay even on frontal tooth. Some people might do some socket preservation even if the walls are intact in these cases. I'm not blaming anybody if they do something different from what I do, but in this case, I don't see any troubles in going immediate placement, immediate temporarization. And of course, I need a literature support all the time. I do need a literature support. Why do I need a literature support? Because I want to play safe and I want to be, consistent, as I say. I always want to do the things in the right way. Looking at the literature, this systematic review is talking about partially edentulous patient. Gallucci is showing us what is scientifically and clinically validated, what is only clinical documented, what is not sufficiently documented. So you shouldn't go for the red zone ever, never. But what else? I have that systematic review, this systematic review and meta-analysis saying that in fixed partial dentures, all the protocol will work, and I have the same and a high rate of success in a follow-up over 3 years. So I know that I can be successful if I proceed this way. And why you should use an immediate approach and being a little bit more brave, but I don't feel that you're braver if you do an immediate placement and an immediate temporization. Of course, your patient is much more satisfied by an immediate approach. It's faster, less surgeries, less time, and the patient comes with the tooth and leaves with the tooth. So, and this is a consensus conference from the EAO. So I'm sure that all the patients, if you ask a patient, you want to go and wait a year before you have your final restoration, or you want to wait a few hours to have a temporary, they will go for a few hours for the temporary, I'm sure. Plus, the immediate placement might contribute to the soft tissue stability. Immediate provisionalization might contribute to the maintenance of the soft tissue when you're doing an immediate implants. So matching the two things, combining the two things might be very helpful for you when you're doing cases like that. And you look at the very recent systematic review, 2023, systematic review and meta-analysis, the final consideration is the immediate implant placement and loading is conducive to the preservation of physiologic soft and hard tissue architecture. So why you want to choose something different? If you're capable, if the literature says that you can do it, why you want to do something different and take more time to finalize your case? Now, let's go back to Elvira. So she comes in, I want to get rid of the small infection of the front tooth. I take out the crown. So I wait and I'll give her let's go back. I give her an Essex or a Maryland, something she can go around for a couple of weeks while the soft tissue will heal. Then I go to my computer, I start studying, placing the implant, talking to the prosthodontist, to the lab, which way we should go. So you do a classical digital planning. You place the implant, you go subcrestal, you decide the length of your SRA you want to place. Then you call Elvira and said, Elvira, we're ready. 2 weeks after, 3 weeks after removing the crown. She comes in, healed is completed, soft tissues are nice. Then you check the guide you have in your office, make sure that this is so you're sure you can do the surgery. People say that you should call the patient in advance, but so far I never had a problem, knocking on wood, with my surgical guides. So we're ready to start the surgery, extraction, dramatically gentle extraction, insertion of a BLX implant, talk about 35 Newton per centimeter. I can go to a temporarization. Inserting the SRA, placing the temporary abutment, then placing the temporary crown, connecting the temporary crown to the temporary abutment, then send it to the lab so you can refine and finalize the temporary abutment. This will take anywhere in between 15 and 20 minutes. In those minutes, I take the time to adjust the socket using some xenograft, as I've done in the previous cases. You've seen an immediate delay, the jest at the crest of the implant, avoiding the invagination of the soft tissue. I do some soft tissue grafting with axinoderm. Then I use a fleece to maintain the clot, a couple of 6-0 resorbable stitches, and I'm done. Again, why I'm doing this procedure, why I'm placing the hard tissue, the xenograft, because the literature says that this helps in maintaining the buccal bone thickness. This is a systematic review from April 23. And the soft tissue is doubt in this, we have some doubt about using the soft tissue, but using the soft tissue is very fashion. Soft tissue is the issue, and bone set the tone, all these sentences. But basically, soft tissue grafting might help maintaining the contour and immediate implant placement and provisionalization. So you should go for some soft tissue grafting especially when you have a thin soft tissue, I would go for soft tissue, augmentation grafting. This is the case at the end of the surgery with the delivery of the temporary abutment. This is the radiographic aspect of the case. 3 weeks. I'm happy. She didn't have any problem. She goes, of course, on a liquid diet and then on a soft diet. She comes in a 3 weeks follow-up. Perfect. Contour is fine. I'm happy. Now I can go for the final restoration. when I look at the final restoration, I always keep in mind that the article by Gomez Meda, published in 2021, on the emergence profiles of the final restoration on implants. Sorry. When I go final in these implants, in these cases, I consider these cases shallow because I'm bringing the connection away from the implant. I'm not that deep in the connection. I place the SRA, I torque it down to the final torque, and then I work above, on top of the SRA all the time. So the prosthodontist will never interfere with the soft tissue healing. He will never touch that. That's a one abutment one time. But anyway, this is the shape of the final restoration I want to have. I discuss with the technician, with the prosthodontist. He shows me the final restoration, and we compare the final restoration to the article. Perfect. Boom. Ready. Elvira comes in, screw the final restoration in, more than happy. Stable, occlusal, the tissues are very nice. 2 years later, perfect. Still stable, not a change. Radiographically, perfect. Happy. I'm really happy with a case like this. Just by placing the implant 2 millimeters subcrestal, by using an SRA, using a one abutment one time, and using a long abutment. This is perfect. That's the way I go now in every single case I perform. I have a small clip of the case. Okay, this is Elvira, as you've seen before. Small flap, very small flap, because the soft tissue healed, almost closing most of the time you don't need to release a flap at all, because most of the time you have a broken tooth open and you have the socket, the alveolus right there. But in this case, you didn't have much showing of the root, so I elevated a small flap, a very small flap, and in order to reach a root and to be gentle and not dramatic, as dramatic as possible. So small elevation, with gentle instruments, very small periosteal elevators. And I remember when I was in at Tufts University, and I went through oral maxillofacial surgery at Tufts University. As an oral surgeon, we were always teasing the periodontists that they were using the small instruments. Now I'm using the small instruments like I was like they were doing back then. I was back in 93, 94, but that's a long time ago. But anyway, elevating the flap, then gentle elevator, very, very slowly. This is a flexible elevator. You can't see it now, but it's a very thin, flexible elevator. It goes into the PDL and into the space in having a very atraumatic extraction. You see, very gentle, very gentle. Once that the root is completely loose, you take it with a mosquito and you take the root out completely. See, I mean, you don't need any forceps to do this extraction most of the time. And then you clean the socket with see, you make sure that all the plates are, all the walls are intact. You see the root is completely extracted, and there are no root tips or a fragment left over. This is the guide. Then you insert the guide, then you start doing your surgical insertion with the kit, with the surgical guided kit, and you go according, of course, of the according to the to your planning. You know which implant you're gonna place in terms of length and diameter, of course, and you keep drilling until you what was suggested by the planning. We're going to 3.2. I found it easier to remove the guide by removing the surgical guide and then inserting, taking out the guide, the drill guide outside the mouth. So it's much easier. You don't run the risk of breaking your guide, your surgical guide. Then you go up to 3.7 millimeter, and then you're basically set. You're ready to insert the implant, and you go with the insertion, of course. With an SLA active. Most of my implants for these cases are active, SLA active, because I want to go faster to a final restoration. Deliver the implant. I usually go with handpiece. I don't go manually at the beginning. I go manually just at the end to reach the torque I really want. So I go ahead with the insertion. Once that I reach high torque, I go manually to just set up completely the implant. I'm happy with the placement. I need the 1 millimeter to dipping the too deep to place deeper the implant. So I go manually. And you seen the picture before in the slides that there was above 35 Newton centimeters. So once that I reach high torque and I'm happy and placement is in agreement with the planning, I go ahead and I place the SRA. I know the length of the SRA from the planning, so there is nothing new. I have everything on my tray. The assistant gives me whatever we prepared. Once that I torque the SRA, I go with the temporary abutment. Place the temporary abutment, placing the temporary restoration with the guide, connecting the temporary restoration with the temporary abutment. And unfortunately, even if you're a surgeon, sometimes you have to be a prosthodontist. I'm just kidding. Of course, we're dentists. We can do everything. We're capable of doing everything. So you connect this abutment to the restoration. You remove it, you wrap it out. It goes to the laboratory that does to refine and shape it and cut it and make it the way I want it. It will take it anywhere, as I said, in between 15 and 20 minutes. Preparing the xenoderm to insert the xenoderm to achieve a better contour of the soft tissue. This is mucoderm, actually. So I insert it. Sometimes I suture it. Sometimes I don't. This time I think I didn't suture it. Then once the xenoderm is inserted, then I'm happy with the insertion. I take care of the hard tissues. So I take some xenograft. I only want xenograft there because I want something that they won't resorb and will be stable in the long term. I don't go deep. I don't go I don't fill all the gap. I just fill the crestal part of the gap. Then once that I'm happy with the hard tissue all around the implant, if I need, I will place a fleece on top of the xenograft. So the fleece just helps the clot to form and to maintain the grafts. I mean, because in 24 hours, the fleece is completely gone. So it's something that won't stay that long. That won't stay that long. Here we go. Once that I'm happy, and I like the way it looks. I clean everything out. I mean, I take the extra granules away from the field. Small fleece, preparing the fleece, putting the fleece just on the buccal aspect, because that's where the clot has to be maintained, where is the mucoderm, where is the xenograft. And then I place 2 stitches, 2 interrupted stitches, mesial and distal, and then I just wait for the temporary. But by the time I do this, the lab, we have an in-house lab, so it's easier for me to do all these things here. By the time I finish suture, I will have the temporary ready. Okay, interrupted, easy, nothing special. But you see the contour with the mucoderm. It's very nice. Mucoderm can be used when you have already enough to keratinized tissue, and you have enough within the soft tissue. Sometimes I use the autologous, but in some cases, in cases like this, I use mucoderm, and so I don't need another surgical site from the palate, so the patient won't be uh, complaining about burning of the palate and things like this. Suturing, finishes suture. As you can see, I have very meticulous assistants, and she worries about the cameraman couldn't, uh, filming correctly. Now I'm ready. The temporary is back. I put the temporary back in the mouth. Screw, torque it, check. Of course, you want to check the occlusion, want to make sure that everything is fine, that the tooth is out of the occlusion. You tell the patient to be on a soft diet, on a liquid diet for a week, and on a soft diet for another three weeks. You check at 1 week, 3 weeks, and then when you're ready to do the final impression in about 6 to 8 weeks. So I can consider this case successful using the stability after 2 years. But now we see in a case of a single tooth replacement. I always have fun in doing things more and more demanding. So we've done one case, one single tooth case. Let's move to a multi-unit case. This is a very loyal patient of our office. It's a very nice man. He came in with a broken bridge of the right maxilla, posterior maxilla, at the right side. And he comes in and he says, Alfonso, I can't chew anymore. This bridge is coming out all the time. I need to do something. Can you re-cement it? We need to do something. We need to do something. Okay, let's see. I take a look. I take a Panorex first. Look at in his mouth and taking a Panorex. This is an unrestorable. These are unrestorable for sure. So my treatment planning would be inserting two implants and doing a 3-unit bridge from the first premolar to the first molar, and change a crown on the canine. Patient agreed, fine, we're ready. Okay, once we're ready and we have an agreement on the treatment planning, I go ahead and do the CBCT. If something new comes up, yeah, I can always change the treatment plan before surgery, for sure. But you have all the socket intact. You have 3 teeth that definitely need to come out. Nice height, nice walls, nice width. So everything is nice. I can go immediate placement, immediate immediate temporarization. If something goes wrong, I always have a backup plan. I always tell the patient, listen, we're going for immediate temporarization, but if I can't, I won't try to do it anyway, even if there is something that goes wrong. So my patients always know that they come for an immediate temporarization, but we might not be able to do it. Digital planning, going subcrestal, same as I said. To be successful, you had to be consistent. So we're ready. We're planning. We decide the length of the SRA. Patient comes in, extraction automatically, flapless. We try the guide, insertion of the implant guided surgery, of course. Then we place the 2 SRA and we leave the SRA there, torque it down, not doing anything anymore. And the prosthodontist and myself for the temporary will work just on the head of this SRA. We won't touch the connection between the implant and the abutment. So this is very important. One abutment, one time. Deeper implant, long abutment. Placing the temporary abutment, getting the temporary, connecting the temporary to the abutment, then send the temporary to the lab while I'm waiting for the temporary to come back. I place my grafting material into the socket. I take care of the socket, some fleece. Here, I didn't do any soft tissue grafting because it's not an aesthetic area, so it's not very important to have, but still I had a very thick soft tissue. Then I deliver the temporary right away. The patient goes home, soft diet, liquid diet, and soft diet. Not to use the toothbrush, of course, he has to use some mouthwash, chlorhexidine, of course, for at least 10 days, every twice a day, daily. He comes back 1 week later and definitely has used the chlorhexidine. You can tell from the color of the temporary. Then I wait for the healing, 6 weeks healing, and we have the. I was ready to place the temporary on the canine, but he said, "No, Alfonso, don't worry. If it's only for aesthetic, I don't care. I don't want the canine. I'm fine." So I still have the temporary of the canine and I didn't replace it. So he didn't want to go for the crown, which is fine for me. I mean, if it was just an aesthetic issue, I'm fine. I wait a few more weeks, so 8 weeks, 8 to 10 weeks, I take a final impression. Look at the soft tissue around the SRA. Perfect. They're very nice. They bleed a little bit. There is a little bit of connection fibers. Look at the scalloping. You can see here. Perfect. Of course, you use an impression, you use the scan body for the SRA, then you bring the case to the lab, you start studying the final restoration. Once that you're happy with the final restoration design, you tell your lab, okay, go ahead and finalize the case. This is the view of the final restoration, and this is the delivery of the final restoration. Patient was happy. I was very happy. Patient never left the office without the teeth. His chewing is fine. Clinically and radiographically, the aspect is very, very nice. So we used deeper placement, high abutment, and one abutment one time. Now, let's talk about the last thing, this new project. Probably not all of you know that there is a new implant coming out in the near future, which is called the BLC and the TLC, which has the same connection as the BLX and the TLX, and you can use the same kits as the BLX and the TLX. The BLC, the design is a little bit less aggressive than the BLX, but it's very highly performing implant. They can be used in any situation. It's very versatile. It's perfect in stable and healed bone for sure, but I used in the even in immediate placement, in immediate restoration. So it's a very, very good implant. We will see, it's that whoever of you is using the BLT, I think this is the next generation BLT for sure. This is Arturo, comes in with a broken bridge on the right posterior maxilla. The treatment planning in this case was to replace the canine, the two premolars, and the molar. We decided not to go with the canine at the beginning because we didn't have a buccal plate at the canine, so we couldn't do an immediate placement on that side. So we decided to do the immediate placement on the posterior, delivery at temporary on the posterior, wait for the integration. Once we achieve the integration, take out the canine, do some alveolar ridge preservation at the canine, having a temporary with the extension of the canine, wait for the healing of the canine, and place another implant there and finish with 3 implants on for a 4-unit bridge. In this case, I took advantage of this very nice service from Straumann called Smile in a Box. I don't know if you do many cases of guided surgery, you want to take advantage of the Smile in a Box service because I don't have the time to look at CBCT matching, taking a scan, matching the scan with the CBCT, and so on. So I take the CBCT, I take the scan, I send everything to the Smile box saying I want this, this, and that. They send you a preview. If you approve the preview, they will call you on the phone 10 minutes to finishing. This is the implant. You like this way. You like it. You don't like it. This is the SRA that you need to use. You will use this length, this angulation. Perfect. And they will send you the guide and the temporary. Boom, finished. 10 minutes. You don't waste time. You don't have to learn softwares. It's just colleagues, peers to peers, because you're talking to a dentist to finalize your case and to have your guide, your surgical guide delivered. So I have my surgical guide delivered, ready. Patient comes in. I can't try the guide because the patient still has the teeth. Taking out the teeth, going ahead with the guide. Now I know I can open my flap. I open my flap. Nice bone. Took out the molar. And this is the BLC. You see, you can use the BLX system. Inserting the BLC, look at the torque, 50. Wow. I can definitely go for a provisional then. Placing the SRA, one is a 30-degree angled SRA, another one is a straight abutment, is a straight SRA. And then I place the temporary abutment on top of the SRA. I had the temporary produced by the Smile in the Box people, connecting to the healing to the provisional abutment. Then I go to my lab. I finalize the temporary. I deliver the temporary, and this is boom, done, easy. Very nice. The system is very nice. I think the Smile in the Box system service is very helpful for whoever of you doesn't have the time to follow and to do all the planning in your on your cases. And this is very cost effective. Even if you spend the money for the planning, for the surgical guide, you have to spend it anyway, and you will have somebody do it for you. I mean, and in those half an hour, 2 hours you spend to plan a case, you can do other surgeries. You can go and play golf. You can do whatever you golf. You can do whatever you want. And this is the final case. Let's take an X-ray. Let's see how similar it is to the case, to the planning. Perfect. Very happy. So it's really exactly recalls the planning. So I would say that this case was very successful. Of course, it's not finished yet. This is just to show you which is the step we're moving to, with the way we're moving to, the BLC, the TLC. But what can we say as a conclusion? As I said at the beginning, this is cost effective just when you buy the SRA, but then in preventing the marginal bone loss, that is something you can achieve with the use of SRA in all your cases. You're definitely saving money, because the patient won't come back to your office to have treated as for perimplantitis. You know, when you start having perimplantitis, you have to see the patients many times. You can ask the money for something that you placed a year or 2 years back, or most of the time you don't ask the money, and so that's a money loser. So having a problem, it's a money loser. If you prevent problems, you're not losing any money. Even if at the front you're spending more, a little bit more. So as a conclusion, I would say that the use of SRA may reduce the marginal bone level, decrease the early bone loss, and prevent the arising of peri-implant pathologies, along because you're placing the implant deeper, you're using a longer abutment, and you're doing one abutment, one-time procedure. So the SRA will help in all these features. So, and with this, I want to thank you, and I'm ready to answer to your questions. If there are any questions, I'm more than happy to answer to your question. And I hope you like the presentation, and let's open the discussion and have some more fun. Thank you again. Okay, I'm trying to answer some of the questions in the few minutes we have left. And the first question was by Leon. Hi, Leon. How are you? I haven't seen you for the longest time, but he's asking if I combine any membrane when I do the socket grafting, at least the superficial part of the socket grafting. I usually don't. Of course, if I'm doing a major GBR or a regular GBR, I always use a membrane and I tack it down. But in these cases, I never use a membrane to cover my grafting material. Another question is, could you please specify the one abutment, one time protocol? And the anonymous means, in what clinical scenarios do you find this approach to be most effective? Basically, I now use an intermediate element, the SRA, all the time to achieve the one abutment one time. As I said in the lecture, I place the SRA and I never touch it. So that's my one abutment one time. I do it all the time, or whenever I can. I mean, sometimes you don't have enough space and interproximal space or interocclusal space, then I don't use it. But I always try to use it. So when I'm doing my digital planning, I always go deeper with my implants in order to be able to place an SRA. Basically, if I can have an SRA of 3 millimeter, I'll be the happiest clinician, because that seems to be the perfect number to have a stable marginal loss, marginal bone. I'm sorry. Dr. Saravanan is asking if it's possible to prepare a guide where you don't have a teeth distal to the implant site. Yes, of course you can. You can have your surgical guide leaning and touching the soft tissues if you're doing flapless, or you make it a longer guide that it goes on the opposite side, so it will be more stable, even because if you're opening a flap, you might run the risk of having a flexion of the guide. So you make a longer guide. If you don't have enough teeth, you want to reach more stability of your guide, then you need to use intra-bony pins to fix the guide and to have a more stable guide, of course. Is it soft tissue augmentation a standard part of your treatment protocol, or you have a case selection criteria? As usual, of course, I try to be consistent, but I try to look at the patient first before being consistent. I mean, if I don't need soft tissues, I don't use it. If I don't need hard tissue, I don't use it. But it's very rare that in aesthetic case, I don't use soft tissue, a kind of soft tissue, autogenous from the palate or exenoderm. If it's just matter of thickness more than quality, I go for exenoderm. If it's more quality than thickness, I go with the palate. In the 3-unit posterior bridge, what's the advantage of doing an immediate loading and limiting the patient to a soft height for close to 2 months instead of placing healing abutments or TLX implants? Okay, those are kind of two questions. It's a very good questions, because I was waiting for the tissue level question to come in, of course, because I'm transforming a bone level implant into a tissue level. You might think you're crazy. Place a tissue level and you're done. But the tissue level, the color is decided by the factory, so you can decide the height of your connection, sort of. I mean, with the SRA, you have 3 different measures. You have 2 different angulations, actually 3, because 1 is straight. So you have a bigger portfolio you can choose from. And why I'm going to a provisional on a posterior part of the mouth, because the patient is smiling. He's a nice man. He's outgoing. It's a professor at the university in Salerno, so he's asking for it, basically. And I know that I can be successful anyway. So why don't go for something that it will work? And instead of having this guy going around with a big hole in the back of his mouth. And in nowadays life, if you can now go around with a hole in your mouth, I think it's much better. Patients really will go for this option, I'm sure. The question is, what fleece actually is spelled different than it was as spelled FLEECE, and it's basically a collagen sponge. That's it. And that will hold the clot a little bit longer, but your body removes it quite fast. So I use it when just to stabilize the clot for the first hours, for the first day or so. Then when the patient comes back to the office for suture removal, they usually you don't see the fleas anymore. What torque you achieved for the bridge, for the unit bridge? I usually, if my torque is lower than 35, I don't go immediate. Even if I have a 2-unit bridge, or if I have a full mouth, I might choose not to load one implant if I don't reach a higher torque. So I usually look for 35 above. And as you've seen in the last case, I reached 50. So I had a very high torque, and I feel very confident in load those implants immediately with a torque of 50, of course. Okay. See you in Singapore, Leon. I hope I will be in Singapore. Okay. Any concern about the strength of the screw holding the crown to the abutment for single teeth? Not really. The only thing you have to look at that the SRAs doesn't have an anti-rotational system. So you have to build but I'm sorry, the final abutment for the SRA doesn't have an anti-rotational system. So when you're doing a single case, you have to scan your temporary abutment and make it done in the lab as a final abutment. So it will have the anti-rotational system on the SRA. So that's the only, yes, there is a concern because the final abutment doesn't have an anti-rotational. You have to create a final abutment that does an anti-rotational system included. Would I use multi-unit abutments for single teeth on Braxers? Braxers are always tough. I mean, on a frontal tooth, and if there is not much of worn out, I would, but on the posterior, I'm not sure. I might go for a tissue level in those cases. Braxers, I feel more confident in using a tissue level implant, to be honest. Could we use a T-base abutment instead of SRA? You could, but I have the SRA, which is the intermediate, and I always work on the SRA. I found it easy, and even for me, that I'm a surgeon, I don't do proso. The only proso I do, I've shown it to you tonight. So using an SRA for me, it's very easy. As I told you at the beginning in the presentation, as I said in the presentation at the beginning, you might think you're spending much more money and it's not worth it. I think it is, because in the long term, you see less periimplantitis, you deal much less with patients' problems. You see the patients less and less. So I think it's a money investment, to be honest. Okay, in the last case, I'll justify the use of angulate the distal implant. The justification is because I don't want to go for a sinus lift. Not that I'm not capable of doing it, but in this case, you have to do the sinus lift with the insertion of the implant, and you cannot definitely go immediate. Plus, the lower arch, which I haven't shown probably in this presentation, his occlusion stops at the first molar. So I don't see the reason of being more invasive. I don't have any reason at this moment for being more invasive. I can reach the first molar by put an angulated implant at the first molar. And to be honest, I do sinus lift when I need to. In this case, I really didn't think I needed. Okay, if due to proximity of the inferior alveolar nerve, you are limited in height and have no soft tissue around the implant, and you need to use a short abutment, are you going to have bone loss every time? No, I definitely not. It's like saying that whatever we were doing before doesn't work. It does work, but so, but I think this will work better, especially with very aggressive implants. I found that in the past, we were seeing less perimplantitis than we're seeing now. So there must be something that we've changed in our practice that has changed the long-term success success rate. So, and I think this way of approaching the patient might bring us back to the success we had 10, 20 years ago for sure. At the beginning, you presented a single implant for a replacement of a missing first molar and showed the x-ray which shows a piece of root that you probably left or was a little of grafting material. No, I said this, thanks for the question. I think during the lecture I mentioned it, that he was a referred patient from a colleague and he left a small root tip when he took out the tooth. Sometimes, they just send the pre-op panorex with the tooth. You say, okay, you take out the tooth and send me the patient in 6 weeks. And then when they send you the patient, you see the root tips. I mean, it's not a big deal. You take, it was like 3 or 4 millimeter. You take it out and you place the implant wherever you wanted to place without, that small root tip won't interfere at all with your final outcome. Is there any concern while placing tilted implants unilaterally? Honestly, not. The literature says that you might tilt implants, especially along the sinus wall, and so far I haven't seen any problem or any bone loss after years of loading. So, of course, in less than 1 hour, I can show all my cases, but if I had more time, you will see that I've been doing cantilever on 2 implants and 3 teeth, posterior teeth, anterior cantilever, posterior cantilever, and they really, so far, they don't affect the long-term results. So I don't have any concern, to be honest. I will be more concerned in doing a sinus lift in a patient that probably is a smoker. In Italy, a lot of people smoke, so you have to do a sinus lift and be more invasive. Plus, you won't have the bridge right away. I mean, the provisional right away. So, of course, if first choice might be not placing an angulated implant, I agree with you, but do I have another option? Yes, I do. When do you use this option? If you have an old patient, a smoker, somebody that doesn't want to have a surgery, now they do zygomatic. Zygomatic is more invasive than doing a sinus lift for sure. So, but we have different options to treat the same patient, and I always use the one that fits the patient better. In agreement with the patient, of course. What point what torque do you put the SRA or the multi-unit abutment right after implant placement? It depends on the torque of the implant I have, but usually with an SRA, you can go for final to 20, 25 top. I mean, I don't go over 25. 20 is usually more than enough. Would love to see more webinars showing your tilted unilateral implants. Of course, if I had the chance, I will definitely. Okay, so we're done. I don't have any questions. Time is gone, and I want to thank all of you to be here with me this hour, and I hope you enjoyed and it was helpful for everybody. And anytime, and if you have any questions, you see my email, please don't hesitate to write me anytime you want for any concern on anything. And I hope to see most of you in Singapore if you guys are coming, or somewhere around the world. And I really enjoy to discuss with you this topic today. So thank you very much. and have a great day, rest of the day. Have a great evening for whatever is in Europe. Have a great rest of the day for whatever is on the other side of the planet. Thank you very much.